2, 1. We are live, sir.
A very good evening and warm welcome to all delegates and today's eminent faculty for today's program called CLEARTalk. We have India's eminent faculty to talk about CLEARTalk and the expert panelist for today. But before we start our program, I'd like to give a brief introduction about CLEARTalk. CLEARTalk is one more facet of Unite Against Dyslipidemia from Zydus Life Sciences. And my name is Satish Rama Joshilkar. I would like to welcome you all on this evening, clearing all our doubts on bempedoic acid. And we have one of the best faculty to discuss about the recently conducted clear outcomes trial, which was presented in ACC, American College of Cardiology. We have today's eminent speaker, Dr. Johann Christopher, sir. Sir is a cardiologist and he's the director of cardiac imaging care hospital Hyderabad. He has numerous national and international publications in the field of cardiac imaging. He has given multiple orations on cardiac imaging at local CSI and national CSI forum. So we have one of the best speaker here, Dr. John Christopher. He is the principal investigator of many leading trials like MEDIC, ICARIUS, CONSERVE, Ischemia and SELECT. And he's also executive member of Asian Society of Cardiac Imaging. I would like to welcome sir and thank you for your time for today's CLEARTalk. Our first expert panelist today is Dr. Ratan Jha, sir. Conducted many teaching 15 years at Medwin and Vinci Hospital examiner for DMB, sir, publication of 700 till date. So one of the expert faculty here, expert panelist here, Dr. Ratan Jha, sir. Sir has authored many multiple chapters in various books, awarded a fellowship in 2011. Sir has special interest in RT, lupus, hepatitis, acid-based disorders, and practicing nephrologist for 26 years. He has huge experience. Like welcome.
Screen gone. Satish, your screen gone.
So sorry for
interruption. There's some problem with your audio.
Dr. N. Papa Rao, sir, is senior consultant, physician, HOD of Citizen Hospital, Department of Medicine, Hyderabad. Sir was earlier senior consultant physician and head of the Department of KIMS Hospital. Sir has worked in various hospitals in Hyderabad, worked as a consultant for Indian School of Business, worked in Kingdom of Saudi Arabia. Sir is conducting antenatal clinics 2 times a week. Sir has huge experience. He is a key resource person in COVID. He was key resource person in COVID-19 team, diplomat in National Board, and professor and guide, postgraduate teacher. So I would like to, it's my honor to welcome all the expert faculty, panelists and today's eminent speaker, Dr. John Christopher, sir. I would like to hand over this session to Dr.
Thank you for the kind introduction, Mr. Satish. And I'm just going to share my screen. I hope my audio is good.
Yes. Audio.
Yeah.
Full screen?
Yes.
Okay, I'll start. Special thanks to Zydus for this platform. As always, they're at the forefront of any important academic activity. A big thank you. Thank you to my senior chairpersons for being panelists. So we will start with CLEARTalk, and I think it's a very interesting talk that we're going to have today, looking through the lenses of a clear outcome trial on bempedoic acid. Now, we're all aware for the last 3 decades that lower is better in terms of cholesterol, just like it is better for blood pressure and sugar control. An approximate 18 milligram per deciliter reduction in LDL will give you an approximate 23% reduction. And if you look at the data here, you will see that as the lipids come down, you're getting a very important and robust reduction in the major vascular events. And the maximum reduction you can see is with PCSK9. And apart from the surgical data, statins are closely following behind. So we are happy with this very clear linear relationship that for every 18 milligram per deciliter reduction, we are getting a robust reduction anywhere from 11% to 36%, depending on how long you're in the trial and how long you're on a statin. So just like the legacy effect of diabetes, the longer you're on a statin, the more the reduction that you're going to get. And the reduction is very robust at the very highest risk group, which is the cardiovascular disease plus diabetes, and also in the lowest risk group, which is no cardiovascular disease and no diabetes. So you will see that from a 62% 5-year risk, you're able to come to 10% 5-year risk, almost 6 times, 1/6 the risk if you can get your LDL down. And the same thing we are seeing at a smaller quotient, that in a low risk patient also, you're getting a almost 4 times risk reduction if you can get your LDL below. So what is very clear is that LDL level and cardiovascular events have a linear relationship. The lower you come, the better. The longer you're on a statin, you're better off. So we are very clear with that basic principle. And then moving on, we are going to address 2 big questions which are hanging over our heads. And the first one is, do all statin users achieve LDL goals as per guideline recommendation? And the second burning question is how to achieve the LDL-C target after you're maxed out on statin. Both very important questions. We'll try to answer it with today's talk. Now, we also know that LDL-C, though important and lower is important, we know the side effects if we can get too low with the drug. So what the LAI, Lipid Association of India, the European Society and the American College have done is to have a cardiovascular disease risk stratification. So the lower group, as defined as someone who has a lifetime risk of less than 30% and has a 0 to 1 major ACVSD score. And we know the scores are based on age more than 45 for male and 55 for female, family history of premature ASCVD, current cigarette smoking, high blood pressure, and low HDL. So if you don't have any of this, you are low risk. And if you have a coronary artery disease established with at least one feature of a very high risk group, which would also involve diabetes and also someone with familiar homozygous hypercholesterolemia. So then you would be an extreme risk patient, and anything in between would be divided into low, moderate, high risk, and very high risk. What is important is that the moment you have an ASCVD or an established heart disease, you automatically get into a very high risk. The moment you have a diabetes, you are already having a moderate risk. So that's very important clinically to look at it. We also have some non-conventional risk factors which helps us tip the balance whenever we have a equivocal situation, which is the apoprotein B more than 110, a HSCRP more than 2, and a calcium score that we do at our institution very frequently of more than 300. Now, the Lipid Association of India has revised their guidelines in 2020 and have given a number of LDL-C targets and non-HDL targets, which we feel is more pertinent to Southeast Asians, very important treatment goals and also goals to consider drug therapy. Suffice to say that we are looking at a less than 30 LDL goal if you come under the extremist of risk, that is, you have a established heart disease with a long-standing diabetes. And of course, the low risk group would be less than 100. Now, if you look at the European data, they are fairly similar, and there has been a movement from 2016 to recently 2019, in which the targets have become a little more aggressive, being 115 for the lowest risk patient in LDL and going down to almost 55 for the very highest risk patient. So it is important as physicians that we understand our patient, we do the KYC of our patient before you assign an LDL goal to them. So getting the LDL down to 100 is clearly not enough if you have a very high-risk patient. Now, when you have these new guidelines, let us see how the Europeans do. And we saw that data from the Da Vinci study, which looked at almost 6,000 patients, which had an equal mix of primary and secondary group. And when they were looked out, there's very interesting findings. Now, the European data comes from Central Europe, where you don't have the East European relatively poor countries, but the rich Western European countries, including France, Germany, and Belgium, Luxembourg, Italy, and Switzerland. And this is the data that we saw. About a third of the patients are receiving high-intensity statin, only 30%. And for those who are getting a high-intensity statin, only 1/3 or 30% were reaching their lipid goal. Now, you know the lipid goals that I spoke to you about, and this is the data. Now, when we look at very high-risk patients, we define those patients, we are seeing that again, only about a third of patients in the very high-risk group, that means they have at least an ASCVD with diabetes, only a third are receiving high-intensity statins. And for those who receive those high-intensity statins, not even a third reach the lipid goals. So there is a big gap between the cup and the lip, so to speak, in that your statin use is low. And even if you do use the highest dose of statin, we are nowhere reaching our aggressive lipid goals. So that brings us to the second question as to how are we going to do it if this is the problem. On one hand, we are keeping aggressive lipid goals, but our conventional workhorse therapy is not able to reach us. So when you have an ASCVD patient, which is the highest risk group, you look at the LDL, and then you look at whether this patient has an underlying ASCVD with events. For example, somebody has an stroke or peripheral arterial disease. Then you look at whether he has an underlying familial hypercholesterolemia. And the third group is the group we are interested in patients who have a complete statin intolerance. And then you would apply the medication starting from the high-intensity statin, which can get the LDL down to about 50%, to the highest risk group, where you have a high-intensity statin, estimamide, and PCSK9. The same thing would apply to the familial hypercholesterolemia group, where you would have a high-intensity statin, a combination, fixed drug combination, which is very well available now in Europe. And thank you to Zydus for bringing that to India at a good price. And of course, PCSK9, and that gives you about an 85% plus reduction, which is really good. Now, for those patients who cannot tolerate a statin, again, the combination of bempedoic acid with estabile added to a PCSK9 is getting you a similar reduction. So that is very, very good and interesting for us because we have about 15% of patients in our practice cumulatively who cannot tolerate statin. Now, if you look at this observational study of around 23,000 odd patients who were prescribed a high-intensity statin, about 66% of patients did not even take the medication. And out of those who took it, more than 50% had a drug interruption after the first month. And you can clearly see that if you are not adhering to the statin therapy in red, your mortality goes up by almost 16% at the end of around 4 years. So we are very clear that LDL is important. The first drug that has to be given is a statin. No or non-usage of statin will lead to a significant MACE or mortality. Now, where does our new kid on the block, bempedoic acid, which is an ATP citrate lyase inhibitor, work? Now, the indications at this point of time, and this is fairly new territory, is the first group of indications is for a patient who has a maximum tolerated statin dose and who still continues to not reach the lipid goals for his category. And the specific areas of patients are mixed dyslipidemia, familial hypercholesterolemia, and obviously an ACVD patient who has had multiple MACE events over the last calendar year. The second group is a relative or complete or total statin intolerance. And there the patient can either not take a statin at all, or is able to tolerate a very small dose or low dose statin, which is generally defined as 20 milligrams of atorvastatin and 10 milligrams of rosuvastatin. And these are the two broad indications that we have as of now to use the drug. The good news is that the drug has a single dose and it is 180 milligrams. And the other good news is it needs to be taken only once a day. Now, if you look at the journey of bempedoic acid, you can clearly see that in a very short span of 3 years, right from its approval by the US FDA, which is the premier body for drug release in the United States, in February 20, it's had a great journey over 3 years. And currently, in April 23rd, got its last recommendation from the ILEP Society for use. What is important is in March of this year, we had the most important information that we were all waiting for, which is the CVOT trial. We already got data from the CLEAR trials. There are about 4 of them, wherein we got to know the safety characteristics of the drug, but we were waiting for the most important outcome data, and we have that also. Now, just moving a little bit into the biochemistry, we are all aware of the lipid synthesis pathway. And if you look closely, you will see just upstream of the statin reduction pathway, which is the methyl coaxylase pathway, the ACL pathway is just 3 steps above that, and that is inhibited by the active form of bempedoic acid, which is bempedoyl-CoA, which is got by the enzyme ACSVL1. Now, the good news to this very important biochemical fact is that the enzyme ACSVL1 is not present in the skeletal muscle, and therefore, bempedoic acid cannot be converted to its active form, bempedoyl-CoA, in the skeletal muscle, and that makes it a huge plus to be used in those patients who have significant muscle issues when they use statin. So already in the LDL pathway upstream, when you decrease the cholesterol synthesis, then in turn, whatever less residue is coming, the statins will block that. And by decreasing the cholesterol synthesis, what happens is there is a positive feedback, and you get an LDL receptor upregulation. And by increasing the LDL upregulation, what happens is the LDL cholesterol, which is circulating, gets bound to it and it gets ingested into the liver for further metabolism. So by increasing the LDL-C receptors, we are in a very good position to have an increased amount of LDL reduction over and above what the statin can get. Now, the other important biochemical pathway is that by blocking the O2 pathway in the kidneys, what happens is that the uric acid is unimpaired production, and therefore you have a mild hyperuricemia when you use the drug, which, unless you already have a patient with gout, really does not matter in the clinical data that we have. Now, if you look at the pharmacokinetics, you will see that this drug is truly a once-a-day drug with a half-life of around 21 hours. A majority of the excretion is by the renal route, 5% is by the intestinal route, and about 2% is unchanged to the kidney. Now, what will be good news for the nephrologist is that no dosage adjustment is necessary. And whatever data we have, you can take it up to about 20 ml per minute GFR tentatively. And it has not been studied in patients with less than 15 ml per minute or on patients on dialysis. And mild to moderate hepatic impairment up to a CP class C, no dosage is required. All patients tentatively should have a serum uric acid as baseline, but there's really no cause for worry except a mild increase in the uric acid, except for those who already have a past history of gout. Now, the other dreaded problem, which has been seen in a very, very small cohort of patients, and the cohort of patients looks like this. They're generally elderly, they're already on steroids or fluoroquinolones, they already have an underlying renal failure and a previous history of tendon rupture. And these are the patients who will have a sharp ankle pain and either can have a severe inflammation or a tendon rupture. So in our practice, an elderly person on steroids with an underlying CKD, end-stage renal disease, who also have some ankle pain, I think it's a good idea not to give it. Now, if you're going to be using simvastatin more than 20 mg and pravastatin more than 40, and I think we're lucky in this country that we use neither of these drugs, then again, there is a problem and you have to discontinue the drug. The drug has not been studied in pregnant and breastfeeding women, so it's better not to use it in that group. So these are the broad safety regulations that we want to give you for using the drug, and looking at them at a glance, you will agree with me that this drug has a huge margin of safety to be used in most of our patients. And finally, with all the safety data from the CLEAR group, the CLEAR Harmony, and the CLEAR studies, we are very happy with the efficacy as well as the safety. But it was in ACC 2023 March, headed by Dr. Stephen E. Nissen, based on the CLEAR investigators, that we finally got the big answer that we were looking for, that this drug goes more than being safe and by reducing LDL, but it actually decreases events. And this global CVOT trial was primarily done in patients who were statin intolerant. This statin intolerance was based on the physician's premise as well as on the patient's request. So a patient who would be intolerant or who would not like to take the statin could be taken into this trial. And apart from the screening, there was a 4-week run-in period on the drug. And then the two groups, one was the 180 milligram per day group of bempedoic acid, and the other group was placebo. Almost 14,000 patients were taken into the study with a 1, 3, and 6 months phone contact. And at the end of the study, almost 1,620 events have been recorded. And based on this, the results have been computed. The follow-up is been about almost 4 years for most of these patients. Now, the 4-point MACE included a cardiovascular death, non-fatal MI, non-fatal stroke, and coronary revascularization. The group involved the primary prevention as well as secondary prevention. And the basis of the study, as we have already discussed, is that 10 to 15% of our patients generally are intolerant. Either they have a minor or major intolerance. And that's the group we want to target with bempedoic acid. And the CLEAR group of studies showed us efficacy and safety, but we did not see the CV outcomes. And therefore, the CLEAR outcome trial was born. And with this, we now have data that the drug is not only a good LDL cholesterol lowering agent, but it is able to reduce by around 20% the primary endpoint 4-component MACE, including non-fatal MI and stroke, coronary revasc, and cardiovascular death. Among the hierarchical testing, the 3-point MACE was kept as the number one, that is MI, stroke, or CV death, followed by the other parameters. Now, if you look at the demographic data, both the arms were fairly equally matched. The patients were mildly obese. They were elderly patients. They all had an elevated CRP, which is again important. And they all had a mean LDL of around 140 milligram per deciliter. They were equally divided into the primary and secondary prevention group, and also a good number, around half of them, I believe, were also diabetics. And about 20% of them in both the groups were also on statin use, albeit a very small dose. Now, the primary results looked at the 4-component MACE, the 3-component MACE, fatal or non-fatal myocardial infarction, and also coronary revascularization. And you can clearly see that the relative risk reduction have been statistically significant. We got a robust 13% reduction in the 4-point, 15% reduction in 3-point, a 23% in MI reduction, and an equally good 19% reduction in coronary revasc, which was really excellent because most of these patients were fairly high-risk patients, at least 50% were high-risk, and 20% were already on statins, both the groups. So on top of the statin, we were able to get this benefit. So you can clearly see here the 4 groups that bempedoic acid showed its superiority. The MI group, the coronary revasc group, the 4-component MACE, 3-component MACE, and the MI and the coronary revasc group, which we've already discussed, leading to a robust 20 to 21% reduction in the entire 4-point MACE. In addition to the 20% reduction in LDL, as you can see, a significant drop in LDL right from the word go, and a nice plateauing effect during the entire course of the trial of 4+ years. What is also important, like statins, there was a very healthy reduction in the hsCRP, which we know is a very important inflammatory marker in cardiovascular disease. And we know that irrespective of the LDL level, a higher hsCRP puts these patients at a very, very high risk for MACE. And here you can see right from the beginning, from the 6th month onwards, there is a good healthy reduction of around 20% reduction in the hsCRP, which continues till the end of the trial. When you look at the serious adverse effects, you can see that they're all well matched between the placebo and bempedoic. Suffice to say, there is a jump of almost 50% in the hyperuricemia and gout levels and the uric acid levels, which we now know is an important thing. And as physicians, I think we are wise enough to check our uric acid levels at baseline and maybe do that after the 1st month to make sure that these patients are safe. And we have good agents to take care of uric acid, so that is again not a problem. The conclusion from this large, well-designed trial was that bempedoic acid became the first ACE inhibitor and the first oral non-statin. We know that PCSK9 did that before, but that was injectable, to demonstrate a statistically significant reduction of MACE4 events, which included a non-fatal MI, a non-fatal stroke, coronary revasc, and cardiovascular death in patients who are at high risk of cardiovascular disease with a documented statin intolerance and an elevated cholesterol. Now, this important statement helps us to put our patients in the right frame when you're using bempedoic acid. So you have to document a statin intolerance, you have to have an elevated LDL-C, and these patients should be at a fairly high risk of cardiovascular disease to use the drug. So therefore, ladies and gentlemen, bempedoic acid, the new kid on the block, ACL inhibitor, is an effective alternative for statin intolerant patients. This is not an alternative for statins. This is not an alternative to avoid using statin in patients, but it is clearly an alternative for statin intolerant patients. And the clear outcome clearly showed that the drug is well tolerated in a good mix of primary and secondary prevention patients. There was a healthy reduction of 20% LDL reduction, another 20% hsCRP reduction, which is an important parameter today. There's a robust primary and secondary endpoint reduction, again, altogether about 20%, starting from 13 to 23%. The 4-component MACE, which involved a cerebrovascular event, was also reduced. So therefore, we believe that bempedoic acid is a very effective drug to reduce MACE, and it helps us in one group of patients inch closer to the aggressive goals set by the LAI and the European Society. And on the other hand, gives us a very viable alternative along with ezetimibe in those patients who are clearly statin intolerant. And we see them in our practice ranging anywhere from 10 to 15%. Thank you very much. And thank you for the opportunity. And over to my chairpersons.
Thank you so much, sir, for this wonderful talk. I missed out one introduction, sir. I would like to apologize for that. And I would like to give introduction of Dr. Nitin Reddy, sir. Sir is a DNB endocrinology, consultant endocrinologist at AIG Hospital, Hyderabad, completed his DNB endocrinology from CARE Hospital. Earlier, he worked as a consultant endocrinology in CARE. And he is also co-investigator in 3 clinical trials like Gemiliv M study, 18F, MC, GPA, HK, and Focus study. Sir has many publications to his name. I would like to welcome Sir also, Nitin Reddy Sir also, for this as an expert panelist. So
Thank you. Thank you.
So before we start, I would like to ask Dr. John Christopher Sir that you initially recommended that ESC, as per ESC 2019 guidelines, the LDL cholesterol reduction should be as low as 55. So there's one question online that how low one can go with LDL cholesterol reduction, and are there any neurological complications which are associated with it?
Yeah, so I think this question has been looked at in various forums. And although the European Society has gone to 55, we now know that 45 is the new sort of talk in a very, very high risk patient. So if you look at a group of patients, not patients, a group which stays in the Andes Mountains near Peru, some US researchers sort of went and looked at them. I think they're called the Pima Indians, if I'm not mistaken, and found that these people live to about 100 average. And they're completely cut off from the outside world, which means there's no access for Pizza Hut and McDonald's to enter there. And when they looked at their cholesterols, fasting LDLs, they found them to be anywhere between around 25 to 35. The second data comes to us from newborn data, neonatal, where the average LDL cholesterol is around 25 to 30. And these are the two small data that researchers are looking at, which clearly shows that on a large scale, getting to 25 and 30 has no major consequences in terms of the neurological problem you're talking about. But obviously, these patients have to be closely monitored, and these levels are reserved only for the highest risk patients and not for the average primary prevention, which we have safely pegged at about 100. So I certainly think there is no risk, but again, as physicians, it is our duty when we are getting the LDLs down so low, we need to take those precautions and watch carefully.
Thank you so much, sir. I would like to ask next question to Ratan Jha, sir. So being a nephrologist, sir, I would like to understand from you the usage of bempedoic acid in your state of practice. Being a nephrologist, how you see bempedoic acid?
Sir, you have to unlock your. You have
Sir,
to
you have to unmute. Yeah.
Hello. Am I audible now?
Very much, sir.
Yes, yes.
In the nephrological practice, dyslipidemia is quite common. We were waiting for this CVOT trial to know about the safety of this drug in the context of chronic kidney disease. What I understood from this trial is that this drug can be used safely till a GFR of 30 ml, because that was the inclusion criteria in the CLEAR trial, and we should try to avoid it in the late kind of sick chronic kidney disease patient, because the drug is basically metabolized and excreted through the kidneys, etc. That is, means there is a possibility of accumulation in the late stage of kidney disease. So this drug, I feel, will be a good drug where patients are not able to tolerate statins till the stage 3A or 3B kidney disease, which is the stage where we need to treat the disease to prevent the complication. Because in the late stage of kidney disease, it has been reported that using statins or any other kind of drug has not made any difference. Like in the simvastatin SHARP trial, which looked at the patient who has received these statins on dialysis versus before dialysis, it was found that before dialysis patients only benefited. But if you delay the therapy till stage 5 disease, then benefits are not. So the simple answer is that this drug is going to be a useful drug, because this doesn't have any kind of muscle side effect that you mentioned, and can be till stage 3 A and B kidney disease as per the guideline. I have not used it, this drug, because I was not familiar with what are the effects and side effects, but it looks attractive because it not only lowers the LDL cholesterol, it reduces the inflammation, which is a part of chronic kidney disease. HSCRP were found to reduce. And this is a fixed dose. There's a 180 milligram dose is there. So patients who are not getting the full dose, because in nephrological practice, I have not seen any nephrologist practicing a very high intensity statin, except in a situation where the person has developed an ACS. Except for that period, I have never seen anybody giving a very high statin, and that's why the goals are never reached. Like what was shown in the trial, only 10% of patients are getting to the goal, even when in the Western literature. So the goals are always unfulfilled. So probably this is add-on drugs, because we always feel that drugs have got more side effects in presence of chronic kidney disease, and this as an add-on drug probably with statins probably is going to be useful till stage 3 kidney disease with a GFR 30 ml. So that is what my understanding is based on the presentation. I will use it to get an idea of how good the drug is so far these events are concerned and so far the inflammation is concerned. One of the important points that was noted in this trial was that this increases the uric acid level as well as the creatinine to a small extent, 0.05 milligram rise. That is happening because this organic acid transport, OA2 receptor, this channel is basically shared by the uric acid, creatinine, and this drug while they are getting transported in the proximal tubule. So any drug which is traveling through that channel is likely to increase the creatinine. So we need to at least tell our patient that there could be a minor change in the creatinine level, but that's a drug effect and not a damage in the kidney, which is always a kind of concern in our general practice. We have seen this problem happening also with fibric acid derivative, fibrates. That's a very common kind of change in the creatinine. The moment I along with statins, like Roja or any other kind of fibrate with statin, the creatinine rises by 0.3, 0.4 because of the shedding of this, the organic acid transport by this drug. So we need to tell the patient that this is a drug effect, and if you stop the drug, the creatinine level comes down. It's not a nephrotoxic drug. It is just a biochemical change that we see many times with many other drugs, like when you're using SGLT2 inhibitors or even the ACE inhibitor, there's a kind of hemodynamic change or some other change, which is not an injury to the kidney that has to be explained. So that is probably my way of looking at it. And once I use it, probably I will be able to give a clear answer to in which context we'll use it. But my feeling is that most of the patients who are not getting the goal can be prescribed this drug with low dose statin, like 20 milligram atorvastatin, which doesn't require dose modification in any stage of kidney disease.
Thank you so much, sir. Throwing your expert comments on bempedoic acid from nephrology point of view. My next question is to Sir Dr. N. Paparao, sir. Sir, you were associated with the COVID-19 task force. You were key person. Dyslipidemia and COVID-19 was associated quite significantly, and there is a recently trial which was published on this. So, how do you see dyslipidemia management? Being a senior physician, how it has to be taken care? Of course, COVID-19 has affected the lipid parameters, but how do you see this bempedoic acid and taking care of uncontrolled LDL cholesterol, which is a major problem?
Yeah. Normally, statin is the most preferred drug either for primary prevention or for secondary prevention. But when statin intolerance, what is defined as the lowest dose of statin cannot be tolerated, or when you stop the drug, you get reversal of all the side effects. So in such situation, we define it as statin intolerance. That is number one. Statin failure. In certain genetic conditions, statin cannot reduce the blood cholesterol level to the. It may not. It may be totally resistant in certain genetic HLA polymorphism. That's number two. Number three, where you cannot reach the required goal. So number four, where there's an underlying inflammatory situation, like in post-COVID situation, or even in diabetes. So my taking on this is, when a primary prevention, when either statin failure or statin intolerance, you don't have many options. You have a PCSK9 inhibitor. It is not tenable, or it's brutally expensive to use for a primary prevention. Maybe you can use it for a very, very high risk patient, even after all the drugs are exhausted. So in a primary prevention where there is effect of statin, and where there is even in Jupiter trial has shown even LDL level is normal, when HSCRP is high, we need to reduce this inflammatory pathway. So bempedoic acid is one I prefer to reduce the inflammatory CRP levels, which even PCSK9 inhibitors has not done. That's number one. With clear harmony trial has shown that in high inflammatory situations like diabetes, compared to placebo, the new onset diabetes is actually less compared to placebo, and also worsening of existing diabetes also much less compared in the placebo group. So this is one situation that it doesn't affect glucose tolerance levels in any way, and it has some beneficial effects on the glucose levels. So these are the situations, and of course, in conditions where statin intolerance, we have to use any other statin. Despite that statin, we cannot go beyond high intensity statin even if you don't reach the target levels. The target, as John Christopher told, they are revised. And also one more point here, if the baseline, it should be at least 50% of the baseline or whichever recommended. If somebody's baseline is 80, and if they have an event or high risk patient, it is not 55, it is 40 for him. So we have to reduce it to 50 to around 50%. In such situations, along with statin, definitely bempedoic acid is going to add to the armamentarium. And as we know, it is much cheaper compared to any other, particularly the PCSK9 inhibitors. And this is I started using the last many months, almost more than 1.5 to 2 years, and it has yielded a lot of benefit. Clearly, as it was shown in the studies, about 20% additional, though the absolute LDL levels are slightly low compared to statin, but when you combine to bempedoic acid with ezetimibe, the overall effect is much higher or even compared to statin to reduce the LDL levels. So by far, LDL level and CRP levels are the most important factors for us. Now, the HDL and homocysteine, all others are not there as risk factors now. So definitely in our practice, particularly for an Indian patient to treat to the target and to reach the goal, I think bempedoic acid has, is very important drug and adds to the armamentarium, and it adds to the average clinical practice of a physician. Thank you.
Thank you so much. Thank you so much. Such a wonderful insight from side. Sir, I would like to come to Nitin Reddy, sir. Sir, Doctor. Yes, sir. Sir, Dr. Papa Rao was saying about new onset of diabetes or worsening of diabetes was not seen with bempedoic acid as compared to placebo. And this is some interesting point of view from endocrinology or diabetes management point of view, because Indians comes with a lot of comorbid condition. Dyslipidemia comes with a lot of comorbid condition. And one such comorbid condition is diabetes. So how do you see bempedoic acid in diabetes patients?
Yes. So yes, as rightly pointed out, gone are those days where we only see the glucose values and then treat our patients only to bring down the glucose values. So we look beyond glucose, and the approach here is to address the metabolic parameters, not just glucose. What do you mean by metabolic parameters? It can be cholesterol parameters, it can be fatty liver, and also it's the weight that has to be brought down. So it's a 360-degree approach. Whenever we're approaching a patient in the primary prevention point of view, then of course it's difficult to convince the patient about the requirement of medicine, because the patient is absolutely asymptomatic. No person walks into the OPD with symptoms and along with the report which has high cholesterol parameters, or for that matter even high sugar parameters, especially in the early stages of the diabetes. This is what we are seeing, especially in the last 1 decade, more and more of young onset diabetes because of the change in the lifestyle. So usually diabetes, especially the young onset diabetes, which is a quite aggressive variant, doesn't come alone. It brings some other adjuvant metabolic abnormalities along with it. So yes, we usually go ahead initially with good lifestyle practice, addressing the areas where they are going wrong. But once we again discuss with the patient after 2 or 3 months with the repeat parameters, then in case the parameters are not getting better, the patient also will be pretty convinced that chalo, this is the time where I should have to initiate the medicines. So now adding to that, especially post 2007 rosiglitazone debacle, now we put more emphasis on those agents where there is safety data pertaining to the cardiovascular outcomes. So when there was a hustle happening in India post DCGA approval for the bempedoic acid, there was no CVOT outcome trial for the bempedoic acid. Of course, after statins, we used to prefer ezetimibe because there was some data in the form of IMPROVE-IT trial, but that was not a statistically significant improvement. So now with this clear outcome data based upon the bempedoic acid drug, now we have a clear edge of the second best agent of choice in the management of dyslipidemia here. But the only thing is the message should be conveyed clearly about the new classification of dyslipidemia, the extreme high risk as well as high risk as well as moderate. Of course, we deal with only high as well as moderate risk, extreme high risk, where we are convenient in sending or referring the patient to the cardiologist. So the 100 is 170 as well as 50. The message should have to be conveyed. What happens is the moment cholesterol parameters are just below 100, maybe 90 or 85, the tendency is to cut down the strength of the statins. So that should not happen like how we explain the patient whenever the blood pressure or sugar parameters are well within the range. We ask them to continue the same medicine instead of reducing the dose. The reduction of the dose should happen only if they fall beyond the lower limit. So that message should have to be conveyed, because the moment we cut down the strength of the medicine, majority of the patients, the cholesterol parameters are expected to come back again. So this way, where we are addressing the cholesterol parameters to the tune of around 50, then we definitely need a second agent. So here we have a clear answer in the form of bempedoic acid after statins. That is my take on it.
Really very interesting fact you shared that 100 is not the number to chase. Would like to come to John Christopher sir. Would like to understand that 100 is not the number to chase, but now Lipid Association of India is talking about 50 milligram per deciliter. So how you define and stratify these patient types? Of course you defined it, but how you see in day-to-day practice that this patient we have to target the LDL cholesterol 55, or these kind of patients we have to target? How you define in day-to-day practice?
Yeah. So again, what is important is we have been good in putting those numbers on the board, and you can see that LAI for the first time as an Indian body had numbers which were actually more aggressive than the European numbers. In fact, as you've seen, the extreme risk category is less than 30, while the European number stops at 55. I found that very interesting because if you look at the Da Vinci study, which I gave you a glimpse, you will see that less than 30% of patients who really need that statin, that is the highest risk of them, are getting the high dose statin. And even if it was offered to them, less than 20% are reaching the target. So that's very, very interesting that even if you actually give the drug, you're not getting to where you're supposed to be. We are very clear about LDL. We're very clear about the LDL linear relationship with cardiovascular events, no doubt about it. And we are also fairly clear when we saw the PCSK9 data that however you decrease the LDL, whether by statin or by using any other method, the MACE events are going to come down. I think that's been quite clear. We did harp a lot over the last decade that statins are great, statins are the mecca of cardiology, and they're all that, and their pleiotropic effects. All that is good. But we do know right now that statins have a serious limitation. They have a limitation in terms of adherence. They have a limitation in terms of physician inertia, and they have a limitations of getting to goal. And now that we know this, we have realized that we need to look elsewhere. The common thing that we in the outpatient look at is basically two groups of patients, which also the CLEAR investigators looked at. One is patients who are already on a statin and not meeting the goal. And I will tell you the real world experience is similar to what the Da Vinci data showed us, in that I think less than 30% of our patients are reaching the goal. It could be because of cost. Patients are scared when you put them on 80 milligram atorvastatin. Within the month of the stenting, they come back to me and say that the local doctor, primary physician, relative in the United States, etc., said that they would have rhabdomyolysis and end up on dialysis. So all these things have to be looked at. You can't dismiss them. Many of them are avid Googlers also. They possibly know more about it than some of us. So as physicians, we have to take all these things into consideration, and sometimes in the interest of all the parties, actually decrease the dose. We do that sometimes in some patients because we would rather have that patient on close follow-up with some statin than dismiss him and then he quietly goes and unloads himself of the statin entirely. So this is the nuances of physician practice, which is not a robotic practice, and you're seeing that in the most highly civilized and the well-economized economies of the Western world. forget about India. And I think India will not even be half of that if you actually take a measure. So that is one group that we want to use the statin. We can use the statin. We have a reason to use it. And for various reasons, we are not able to exploit the full potential, or even after doing that, we are not getting to goal. The goal in our practice generally is less than 70 for a patient with ACVD, and we go down to 55 if the patient has had 2 recurrent MACE events in the calendar year, either a cerebral or a cardiovascular event. We don't look too much at the peripheral vascular disease, but if he's had 2 back-to-back events in a calendar year, then we are seriously looking at 55. And at 55 LDL, I don't think even 20% patients on solo statin ever make it there. So this is a group where we have been desperately looking for add-ons. After the trial a couple of years ago with Estomvir, we have been looking at that molecule closely, and it's available only in a single dose, 10 milligram once a day. And it is complexed by many companies with a statin, usually the lower dose statin. So we have been using that, and we get about 10 to 15% reduction. Again, a very safe, fairly safe molecule. In the very, very high risk patients, we've had to resort to PCSK9. I give it to some patients as a bolus form. That is, I don't give it every 2 weeks. I just give 1 dose, check the LDL. It costs around 18,000 rupees approximately, Indian rupees. And I just give 1 dose, have a look at the LDL. If it's come down, I stop. Because many of our patients, again, as I said, they don't have the government insurance. CGHS is currently having it with the number of letters that you have to give and signatures, which is not easy. You've got to run around quite a bit. Many of my patients are elderly and they would choose not to. But in those patients who are cash paying, we give a single dose of PCSK9, watch the LDL, and if you're coming near to goal, we stop it. We're possibly going to do the same thing with Interstran, which is going to come, I think, by Novartis by the end of this year, where it's a 6-monthly injection. So maybe just a single dose will get our LDLs down, and then we will again watch that space very closely. But I think it is the remarkable benefit that I've been using this drug for the last 6 months, especially complexed with estomide, where you're getting a robust 30% reduction when you use both the drugs, 180 and 10 milligrams. What is even more remarkable is they have, unlike the statins, a very synergistic different pathway of inhibition of cholesterol. One works through the intestinal route, and one works through the HMG-CoA pathway that we're all familiar with through the liver. So since they work in completely different pathways, they become a very synergistic molecule. And you've also seen from the CLEAR data and also the Estomvir data that they are extremely safe molecules up to a GFR of 30. And I've really not had an issue with anything. I've not seen a tendon rupture in the last 6 months. And our uric acids have jumped up by about 10 to 15% only. Never had a exacerbation of gout because we have been able to choose our patients rightly, as Dr. Jha has said. We don't give it in CKD stage 5. We don't give it to somebody who already has a gout on treatment. We don't give it to a patient who's already on quinolone. So if we adhere to the clear outcome recruitment criteria, I think the safety is enormous. And if you have a 30% reduction with these 2 drugs and another about 20 to 30 reduction with the statin you're on, that's 60 to 65% reduction, which is pretty good. And a good number of patients on the triple drug regimen have reached goal, which never reached goal before. The second group that we have used in the outpatient is those patients who truly are statin intolerant. There are about 15% or so in our practice, where we have tried multiple statins, decreased the doses, made it intermittent, and we have failed. It may not be objective, but our patients completely refuse to take the drug because of severe muscle side effects, especially of the lower limbs. And some of them do have a rise of CPK, so we immediately withdraw the drug. Despite all these maneuvers, we've not been able to have much headway. And this is a great opportunity where this drug comes in along with Estomvir, completely safe because of the lack of the muscle enzyme. And we've been able to reach not great targets, but we're able to at least reach some targets, which I think is remarkable in this population. The last group, which I have been able to use it, maybe a little off-label, is very young people who come to me with high LDLs most probably familiar. They don't have any form of atherosclerosis in the form of a calcium score 0, coronary calcium score 0. And here is a place, and they're already obese, they're pre-diabetic, and this is a great place to use a drug, I feel, where you don't need the benefits of statin because he has no ASCVD at all. And he's pre-diabetic, you don't want to push him into diabetes. So I think this is a great role where both the drugs play, but these are just early days. We have only 6 months of experience, and I'm sure when we meet 6 months later, all of us will have a huge amount of data to look at. Thank you.
Thank you so much, sir. I would like to open this forum for our expert panelists to discuss more on this platform. So I'd like to open this platform.
So actually, when the risk comes, patient don't see the risk, and we see as doctors how much is the risk for a patient. Even after he starts using for 3 months, 6 months, and he by himself doesn't see any benefits. So particularly for a primary prevention, how to, anybody has any slogan for these people to convince them how to continue on statin? And most of the times the Indian psychology is, suppose if 1 kilo bendi is 20 rupees, they ask for 19 rupees. 1 kilo bendi is 10 rupees, they ask for 9 rupees. So when you take 10 milligrams, they says, doctor, I will make it 5 milligrams. Please, please, please. Or if somebody prescribes 20 milligrams, he tries to take 10 milligrams or alternate days, something. So he doesn't bother about the optimal control of the risk. So I want to know from the panelists, do you have any slogan for such people to convince?
Yeah, I have a very simple thing that I do. That is one, I do a treadmill, I do a CIMT, and I do a calcium scoring, coronary calcium scoring. The moment they see the atherosclerosis on the calcium scoring film, they get really scared. And if they see an abnormal treadmill, or if they see a CIMT, which is more than normal, and I always keep a normal picture with me to show as a reference. So these are the 3 ways I'm showing them that you are absolutely fine, you're normal, you don't have any symptom, but there is a deep iceberg within you which is going to burst. And when they see that calcium in the arteries, I see the fear, and I found it to be a very, very important way to make them adhere. And this is also available from Western literature, by that calcium scoring helps a great deal in adherence. And I've seen that data, and I've started using in my practice with very good effect.
But not everybody will have calcium scoring who has risk.
The other thing is to use a UACR. I think Dr. Jha will agree that this is a great marker, very easy. It's a urinary test. The moment you have a urinary UACR of more than 30 and definitely more than 300, these people are at very high risk for cardiovascular, for kidney, and cerebrovascular event. So that's again a very nice marker which you can easily get. It's fairly cheap, and of course non-invasive with just a urine sample. I think is a very good way to demonstrate that although they may be asymptomatic, but there is major issues coming up.
Very interesting, sir. So what is your take on Ratan, sir? I would like to ask, and Nitin, sir, what is your take on sir was talking about this one?
The points which have been raised are well understood now, that how to use this drug. This is a drug which to be used in association with at least low dose statin in the context of chronic kidney disease, because many times people of chronic kidney are not able to tolerate the very high intensity in statin. So we use usually 20 to 40 milligram atorvastatin because it doesn't require dose modification. And as most of the patients are not to the target, it is below 100 but never below 70 or below 65. We never try to reach that goal. We are worried about the side effect of the drug. So this drug can be utilized for that purpose, at least to get to the goal that is there. It is to be also understood that there is a kind of reverse epidemiology is theory there in context of chronic kidney disease, that if you find the lipid levels very low, that is also a marker of increased death because of the malnutrition. So before we start using statins, at least we need to be sure that this patient doesn't have malnutrition, which can be easily looked after by looking at the weight as well as the serum albumin and other markers to be sure that this is the right patient to use the statins as well as the bempedoic acid to get to the goal. So the goals that were talked about, 55, 70, 100 and 150, the same things are talked about in chronic kidney disease literature, but the results are not that good, etc. If it is started late. So we use statins. We use atorvastatin rather than rosuvastatin because rosuvastatin requires dose modification in the context of kidney disease. And we start with moderate intensity dose, 20 to 40, depending on the risk factors, because we have to stratify the risk. The risk has been very well shown by that Lipid Association of India, how to stratify the risk based on the risk factors. Because we have many kinds of calculators, where I get confused that which calculator is usually used in the context, that is atherosclerotic cardiovascular risk 10 years calculator, the lifetime calculator, then score 2 calculator, then this LAI calculator. I have never used that kind of score. We look at, most of our patients with kidney disease are high risk because they are diabetics and they are having CKD stage 3 or 4. So don't require any calculator. We know that this is a high risk patient that has to be treated to the goal of 70, but we are not able to achieve that goal because of the dose that we are not using enough, etc. Probably you can use this drug as a second line drug after statins, or without statin if they are not tolerating the bempedoic acid to get to the goal, because it has a synergistic kind of benefit in the form of reducing the inflammation, which is talked with statins also, and reducing the cardiovascular endpoint, which is clearly shown in the CLEAR trial. So this probably looks at attractive combination. After statin, probably this is the first drug, rather than using ezetimibe or any other drug that we talked about, PCSK9 in the context of chronic kidney disease.
Yes, so predominant points about the bempedoic acid are already discussed. So addressing to what Paparao sir has asked regarding the convince the patient for the lipid therapy, especially since past couple of months, where more and more videos of people succumbing all of a sudden. So there is some amount of fear that is there, especially in patients. And we also try to convince them that it's not just cholesterol. You have weight and you have diabetes, and if he or she is a smoker, so they're all risk factors which are adding up to the cardiac event. So that way we try to convince, and also these days, because of the help of the videos, that is also making our job easy. Patients are themselves more worried about the cholesterol parameters. So, but however, we should have to take the help of the data which is in favor of the primary prevention and the advantages of primary prevention, and that we'll have to find out some other way to convince them. And majority of the people are usually convinced with the importance of primary prevention, and it's all about good communication with the healthcare provider and the patient, especially the first consultation. That really matters when it comes to convincing the patient.
Just one point I wanted to raise, that what was said, the calcium scoring. This is usually a scoring based on the CT scan, without contrast or with contrast, because I'm not sure that we have not done this calcium scoring in any of our patients. So what is the comment? Is it calcium scoring on a non-contrast CT of the heart, or where do the scoring, how is the scoring done?
Sir, actually, we have a large experience over the last decade doing calcium scoring. It is a non-contrast scan. It takes about 5 seconds. It's a single breath hold. It's the coronary calcium, no other calcium, because we know that coronary calcium is atherosclerosis and not the metastatic or dystrophic calcification you would see anywhere else. It's a 5-second scan, no contrast, just ECG leads, and the patient walks in, walks out, no preparation, and completely safe, because the modern scanners have a radiation level of less than 1 millisievert. So I think especially in diabetics and CKD, I've been sort of in touch with the other nephrologists. It's a great way to re-stratify your patients who, as you said, are already high risk, but then they go into a very high risk if you can prove that they have a calcium score of more than 300, because we know that CKD patients, because of good management, are now dying more of cardiovascular diseases rather than actually kidney failure. So a coronary calcium score can really put the patients at a much higher risk and put and make you manage them actually even more efficiently. So we have done about, I would say, close to about 10,000 calcium scores till now, and they're very effective, very cost effective, and almost, I'm going to use the word, very low dose radiation of about 0.7 or 0.8 millisieverts. I feel it's a very effective tool, and what is more effective is when the patients see those pictures, they truly appreciate that something is going on in the heart, even though they're completely asymptomatic and they have normal treadmills. They have normal treadmills because we know that treadmill has only a 60% sensitivity and can detect a lesion more than 70%. But we know that most of the heart attacks are caused by lesions less than 10%. So once you're able to convince them, it acts as a very powerful, thing to keep them on the statin.
Sir, indeed, there is one more information would like to give that recently conducted American Diabetes Association. There is a interesting data about primary prevention with bempedoic acid in subgroup analysis. And of course, we have spoken in clear outcomes trial that 13% reduction all MACE4 events. But in this primary subgroup analysis, which was done in primary prevention, there is 30% reduction which was seen in all MACE4 events. So that is some interesting thing would like to share on this platform. So any further addition would like to ask all the panelists, any further reduction in LDL cholesterol, which is of course a recommended choice, but we always see 100 is the number wherein there's a lot of patients who comes with lot of risk, lot of comorbid conditions like diabetes, dyslipidemia, whether patient is having unhealthy lifestyle. Nowadays it is being talked about a lot of things recently. So I would like to ask all the expert panelists to throw some light from their perspective, from nephrology or endocrinology or cardio perspective.
In nephrological practice, and as well in the textbook, the LDL cholesterol goal is written for like CKD patient below 100. And after that, it has to be individualized based on the risk factor that we discussed. So as most of the patients are not able to tolerate a very high dose in statin because there are multiple drugs for their other kind of comorbidities, we probably will have a better kind of this goal-directed therapy with the availability of this bempedoic acid, which is said to be a safer drug compared to the very high dose statin that is there. So my feeling that probably we are going to get to the goal more easily with use of this combination rather than using statins alone. So that is the comment from nephrological point of view. We never try to use fibrate, though that is a drug which is commonly prescribed by our endocrine colleague as well as the cardiology colleague to look at the LDL non-HDL cholesterol goal, because triglyceride is many times raised, but it has not been found to be very useful in many trials that lowering the triglyceride alone has any kind of cardiovascular benefit other than the numerical benefit. So, and that also increases the risk of side effects of muscle pain, abdominolysis, and creatinine rise. So fibric acid derivative in context of chronic kidney disease we hardly use. I do not use it. We use a good dose statins, and in case the triglyceride is high, we are using the drug seroglitazar to look at to reduce the kind of triglyceride. And we find that this is safely tolerated. Whether that has led to a kind of reduction in the long term, that we are not able to be sure about it. But based on the literature, we feel that probably the patients get benefited with this combination.
As far as I am concerned, I am aggressive in controlling the LDL cholesterol level. But however,
Yeah.
sometimes it is difficult to convince. As Dr. John Christopher told, I have this new tool. I will start for those who really need the medication and who really is not convinced about the medication. Possibly the calcium scoring is one simple test that could convince the patient. And however, so the risk is always unseen. So you never know. So I always ask the patient how long you are going to live, and 5 to 10 years of your life is cut off, and the rest of life also you have. At any time you can get a heart attack. You can get any time a. To prevent such things, if you want to use up to you. But if you do, I strongly recommend to use and things like that. If they are still not convinced, maybe I will refer them to Dr. John Christopher.
I think there is a great power in numbers. And as some of you panelists have already shared, thanks to social media and all these young sudden cardiac deaths. And I will just read an excerpt from what Dr. Devi Shetty made a comment after the spurt of sudden cardiac deaths. He made a very bold statement on print media saying that there's nothing called a sudden cardiac death. These were all deaths, a majority of whom would have been easily prevented if a simple sugar, if a simple lipid, or I can't remember what else he talked about, or a blood pressure, or a blood pressure was checked. So I think there's great wisdom in that statement. And I think because of the large circulation and his preeminence and his position in society, we did get a spurt of patients coming for calcium scores. So I think these are good things that are happening today. There's great awareness, and showing pictures I find very, very persuasive for most of our patients who may lack the wisdom of numbers. So I think pictures speak more than 1,000 words. So I think calcium scores are a great way to go. And I already told you that it is a very safe and easy to do technique and freely available in most coronary CT labs in the city. You can easily do it. There's no problem.
Yes, as told by the expert panelists, so always we'll have to prevent the future complications from happening, may it be nephropathy or retinopathy or cardiovascular events. So being aggressive right from the beginning, this is the approach that we also follow, not only just with glucose parameters, but that should have to be with the lipid parameters also. Thank you.
Thank you so much, sir. Thank you, Dr. John Christopher, sir, for being the speaker and clearing all our doubts on bempedoic acid. I would like to thank Ratan, sir, for being there and always putting your expert comments from nephrology point of view. So it was to the point, and in clinic day-to-day practice definitely would help us, all the delegates who are joining live for this program. I would like to special thank Dr. Papa Rao, sir, for being there with us always. As you being a senior physician, would like to pass on the benefits of the recently bempedoic acid, which you would like to pass on the benefits and control LDL cholesterol, and that is the biggest threat. And would like to thank you, sir, for disseminating all the expert knowledge what you have. And I would like to special thank Nitin Reddy, sir, for being there with us and talking about bempedoic acid through the lenses of endocrinology point of view, diabetes point of view, diabetes management point of view. So before we end this session of CLEARTalk, I'd like to hand over this session to Tahir for final conclude. Vote of thanks.
Thanks, Mr. Satish, for giving me opportunity to give vote of thanks. It's a great pleasure to give the vote of thanks with such a expert and senior panelist and the speaker, the eminent speaker of Hyderabad and the nation and the international of the repute. This side Tahir here, senior regional manager, work with Medica division. As Zydus Medica and Zydus is known to bring the new molecules to India. As sir has showed that first NC from India, even to the world, it will be a saroglitazole. And when it comes to COVID, we are in the forefront. Not only that, when dapagliflozin became patent, we opened the door for all. Now for nephrology perspective, I was talking to sir, oxymia is there for those anemic patients. Now for again, Indian patients, those dyslipidemia patients, those who are deprived of any statin therapy, and Zydus has opened the door, especially for those deprived patients with bempedoic acid to India. That is the thing. Now, many other companies have come for last almost 1 year. Recent development has happened for this. Now, CVOT trial has come out. I believe it was a great sessions and great presentation by Dr. John Christopher, sir. He has been using this molecule. I think he has given the real practical experience the last 1 year as he's been using, and with the combination with the ezetimibe, which is approved by European Union also. And we have really been very fortunate to have nephrologist perspective and physician's perspective and endocrinology perspective along with cardiologist. This is the first time ever that we are under one platform, that understanding the use of bempedoic acid, especially in all the specialty. We really thank you very much for the valuable time and valuable insight into this bempedoic acid and the clear outcome trial. I believe our audience and the delegates should have definitely taken the message very clearly about the usage of this bempedoic acid, especially for those intolerant patients and uncontrolled LDL patients. We really thank you, Dr. Ratanja sir and Dr. Paparao sir and Dr. Nitin Reddy sir, and thank you very much, Dr. Johann sir and Mr. Satish for this, sir. And thanks all the audience for the time and for making this program a successful program, sir.